Seems
Okay.
to have out, so I think we can go ahead and start, Sergio.
Yeah, perfect. Thanks, everyone. Good morning, good afternoon. I'm Sergio Carmona. I'm the Chief Medical Officer at FIND. FIND, as known today as the Global Alliance for Diagnostics, brings together many partners in the ecosystem of testing and more recently in surveillance. Together this morning with the ASTMH, represented by Dan, my colleague and friend from FIND as well, we welcome you all to this pretty exciting session. It couldn't be more relevant, I think, today with the emergence of Omicron and the new variant of concern from SARS-CoV-2 designated only about 2-3 weeks ago. And thank to the work done by NICD in South Africa and many colleagues in the consortium responding to the pandemic includes private sector and academics. And we also have the pleasure today of having other colleagues like Sikelele Moyo, which was instrumental in demonstrating the first case of Omicron in Botswana, Priscilla from up north in the continent, and Belinda, who will give us an insight into how industry and the private sector can also respond to the inequalities that today we have with access to testing. Just as you all know, not only testing is key as an entry or a gate into sequencing and genomics. Without testing, we can't really have a good sense of where new variants of concern may be arising. Today, the inequality of testing from the high-income countries is close to 50 times more than that of low-income countries. And we want today to highlight the great work that has taken place in 3 countries, and how could we also maybe in the open session and the discussion later discuss how all these lessons will be of much value in being prepared even better for the next time. I want to conclude by really thanking both Botswana and South Africa for the incredible work, the scientific work and public health work that helped and alerted many other countries in the global north. And very sorry about how some of these G7 countries reacted to that. But let me leave it at that. I don't want to get into the politics of pandemic preparedness and the great work that you've all been part of, and hand over to Dan to introduce the first speaker from South Africa. Over to you, Dan.
Great, thanks, Sergio. And morning and welcome, everyone. Thanks for joining us. As Sergio said, we have a very interesting panel this morning, and we'll let them talk in just a minute. Just a brief introduction. I'm Dan Bausch, as Sergio mentioned, also at FIND as the Senior Director for Emerging Threats in Global Health Security, and then wearing my other hat as the President of the American Society of Tropical Medicine and Hygiene. So welcome from both sources. A great panel this morning for some brief presentations, and then we definitely want to have time for discussion. So feel free to put your questions and points into the chat, and we'll try to get to them as much as we can. And without further ado, then I will turn it over to our first speaker. So Nicole Walter from the Center for Respiratory Diseases and Meningitis at NICD in South Africa, of the National Health Laboratory Service, School of Pathology, Faculty of Health Sciences at the University of Witwatersrand in Johannesburg. And as Sergio mentioned, our colleagues in South Africa and in Botswana have been really the essential component in all this and recognizing of what's going on with this variant in Omicron. So Nicole, over to you. Thanks very much.
Thanks so much, Daniel. I'm just going to share my slides. If you'll give me a minute. Thank you. So just confirming that the slides are visible on your end.
Yes.
Great. Thank you. Thanks. Good morning or good evening, everyone, depending on where you are in the world.
Nicole, you could switch to the other, viewer.
Okay.
Because sure. We see both your.
Oh, okay, sure. Better?
It's probably perfect. Go ahead. Sorry.
Great. Thanks so much. So I'm Nicole Walter. I'm a medical scientist here at the NICD, and I'm based in Johannesburg in South Africa. And thank you so much for the opportunity. I'm going to try and share our experience over the last crazy few weeks that we've had in South Africa with detecting the emergence of Omicron. And really just speaking on behalf of a really great team of scientists in South Africa that worked really rapidly and really around the clock to get this data out and to respond accordingly. So just in terms of an overview of the presentation, I'll just firstly start with just a revision of the World Health Organization Technical Advisory Group. Really, just what do they do, how are variants assigned, and what is their role? And then just briefly go through our experience of the detection of Omicron and the various early warning signs or indicators that we had that a new variant was emerging in our country. So just as some revision, often these are all documents that we don't refer to until the situation becomes very real in our own country. And so this is something we became very familiar with over the last few weeks. And so the World Health Organization has a technical advisory group on SARS-CoV-2 virus evolution. And really they are a group of independent experts that meet regularly to discuss the variants and to really decide when a variant constitutes a variant of interest or a variant of concern. And in terms of the definition that they use for this, it is a new variant or a old variant that meets these criteria. It shows either an increase in transmissibility, an increase in virulence, or a decrease in effectiveness of current measures that we have at our disposal, including public health measures, diagnostics, vaccines, and therapeutics. And obviously, any one of these criteria must be at a global public health significance to be classified as a variant of concern. So currently we have 5 variants of concern. I'm sure you're all aware of the Alpha, Beta, Gamma, Delta, and more recently the Omicron variant of concern, which was designated a VOC on the 26th of November on recommendation by this advisory group. And then I think what is important also just to highlight in this discussion is what is expected by a member state if a VOC is identified. So what response? So one part of it is detecting it, and that's really what we'll focus on in the second part of this presentation. But what is the response that's needed? So 3 things are stipulated by the TAG VE group. The one is to submit complete genome sequences and the associated metadata to a publicly available database such as GISAID. Secondly, to report the initial cases to the World Health Organization through the IHR mechanism. And thirdly, where capacity exists, to then perform field investigations and laboratory assessments to try and understand the potential impacts that this VOC may have. And that's really getting a better understanding of the phenotypic characteristics of the new variant, understanding the new epidemiology, the severity of the variant, effectiveness of our current public health measures, diagnostic methods, the effects it will have on immune responses, as well as antibody neutralization. So then moving on to the detection of Omicron in South Africa. So I really just want to go through the various aspects of where we saw early warning signs and the evolving, the events that evolved over the days after, as we started seeing that something may be happening, and how we responded to that. So just to briefly set the scene in South Africa. So South Africa, prior to this current 4th wave that we are now in, we've had 3 epidemic waves. Each have been dominated by a different variant. Our first wave was dominated by the ancestral virus. This was followed by a second wave, the beta wave, and then our worst wave, which was our delta wave. It was a very severe wave in South Africa. And then really after the 3rd wave, we went to our lowest levels ever that we've seen since the start of the pandemic in terms of number of cases and number of proportion testing positive, until the recent emergence of Omicron, which has really precipitated us going into the 4th wave of the pandemic. So the first thing I'm going to discuss is the laboratory test data. South Africa has a really good system for automatic reporting of all SARS-CoV tests throughout the country. So we have these automated data dumps, which come into the NICD in real time. They come from the public laboratories as well as all the private laboratories. All tests that are conducted in South Africa are reported to the NICD in real time. We then access this data to generate both daily and weekly reports and to monitor trends of both number of tests, proportion testing positive, and the number of cases in the country. So one of the first indicators that we had, just looking in terms of tests, so this This slide shows a testing rate per 100,000 persons by province in South Africa. And we generate this data on a weekly report, which we share on the NICD website. And really, if you have a look here at around about week 45, 46, one of the first indicators we had was an increase of the number of tests. And this was in Gauteng, where it was first observed, followed by Limpopo, another province. And thereafter, really all of the other provinces, we've seen an increase in the levels of testing in all of these provinces. So first indication in the testing data and number of tests being performed. Second indicators, we report on the proportion testing positive, both on a daily basis as well as a weekly basis. On the left-hand side here, you see the daily proportion testing positive, again highlighting that if we look at the interwave period after our third Delta wave, we really went to very low levels in terms of proportion testing positive, and lower than we saw between the first and second and third waves. And then very rapidly towards the middle of December, we saw an increase, a very rapid increase in our proportion of samples that tested positive by PCR and antigen. And this is reflected in the weekly data. If you have a look here from weeks 46, you really start seeing the increase to testing 2.5% of samples testing positive. The next week, 8.5%, that jumped to 25%, and then very quickly to almost 36% of samples testing positive. So really another indicator in the proportion of samples that tested positive, and increasing really rapidly and faster than we've really seen in any of the other waves. Data is also shown by sub-district, so looking at it in terms of locations. So just comparing from the left, this is the proportion testing positive by sub-district in South Africa. And sort of the warmer the color, the higher the proportion testing positive. So the reds and oranges showing a high number of samples testing positive in these sub-districts. And again, what we saw is week 46, we started seeing, so well, like I said, most of the country really was green, very low proportion testing positive. We're all getting ready for a lovely Christmas holiday with very few cases. And then we started seeing sort of a few districts in Gauteng province, and specifically in the Tshwane region, starting to show this sort of increase in proportion testing positive. Some of these were related to tertiary institutions. We knew that there were some outbreaks amongst the tertiary institutions and students in Tshwane. But really what we saw was an explosion over the next few weeks, so spreading all over Gauteng into Limpopo and Mpumalanga. And really in this last week, the week 49, we saw almost really spread throughout the country, and a high proportion testing positive, over 30% in many places in the country. The other thing that's very useful with laboratory data, so we use a number of different testing platforms. This really just is a slide summarizing the testing platforms that we use and are available in the public sector in South Africa. But really one of the first signs, well, we saw the signs in the data, but really when something really sort of stood out to us is when we started seeing a change on the Thermo Fisher assay, the TAC path assay. And this we were alerted to by a private laboratory who contacted us, and they said they're seeing something very strange. They're seeing a large increase in the proportion of samples that are testing positive, and very strangely that there are very strong positives, but they're not detecting the S gene. And so this is really what triggered the sequence of events that followed thereafter. And when we look at this data now, so we have data for public sector laboratories and for one private sector laboratory in South Africa, having a look at all samples that were tested on the TAC path assay, and having a look at what they call the S gene target failure as a proxy for Omicron. And you can see here, if we look at it by epi week and the percentage of samples that were S gene target failure, you see again a rapid increase, also starting in Gauteng province and really being followed by all the rest of the provinces, and that by week 47 and 48, almost all samples being tested on the TAC path assay were S gene target failure. So showing a rapid replacement just using this assay, and obviously there's many limitations with only looking at where this assay is used and what samples it was tested on. But really we saw a rapid replacement of Delta with Omicron in these few weeks. Moving on then to the epidemiological trends. Also, we monitor this very closely and prepare daily and weekly reports. But the similar thing as to what we saw with the testing data is this rapid rise in the number of cases. So on the left is the number of cases by day, and on the right, the graph on the right-hand side is the weekly incidence risk, so taking into account the population denominators. Gauteng is the most highly populated province in South Africa, and really showing straight away this very rapid increase and exponential increase in the daily number of cases as well as the incidence risk. And this is followed very shortly after by other provinces in South Africa. And then another indicator that we use from the epidemiological perspective is the daily effective reproduction number. So if you can see, so if you have a look at this top graph, this is the R number, the reproduction number for number of admissions and number of cases. And about the same period in time, about mid-November, we saw a rapid increase in the effective reproduction number. And it really at about, towards the end of November, was at about 2.5 for the country. But if you just focus on Gauteng, where this outbreak started, it was about 3 towards the end of November. So really lots of signals in terms of the laboratory data as well as the epidemiological data that something was going on, something strange and needed investigation. So this led us to the genomic sequencing data. So as I mentioned, it really was a collaboration with the private sector laboratories who alerted us that they watched the data very closely and started observing something very strange in their tests. And they had seen it a bit before with alpha, but never to this level, and in such a short period of time. So they contacted us and asked if we'd be willing to assist them with genomic sequencing and to try and understand what may be leading to this S gene target failure that they were seeing. So they shared their samples, and we did rapid sequencing of these samples to try and also explain the rapid increase in the number of cases. So we in South Africa, we have what is called the NGSSA. It's the Network for Genomic Surveillance in South Africa. It really is a consortium of 7 different laboratories throughout South Africa who work to produce as real-time as possible sequencing data for various parts of the country. All of this data goes onto GISAID, and we prepare weekly reports also shared on the NICD website. And really the goal is to monitor the lineages circulating in South Africa and to monitor the emerging variants in as real time as can be done. So we have laboratories from throughout South Africa that share, depending on where their closest NGSSA lab is, from both the private and public sector. They share clinical specimens with us, which are then sequenced. And this is where we came across this new Omicron lineage. It really was quite devastating, and many of our bioinformatics scientists were really sort of shocked and said, no, there must be something wrong. Let's just recheck. And then, I don't know, let's just check again. This is something we've never seen before. We better just check and check and check. And then really after additional sequencing and running even more samples and a couple of days of just analyzing on using every pipeline available to us, we really realized that something is going on and that we potentially have detected a new variant. As you can see, it has a large, Omicron variant has a large number of mutations, many more than what we've seen in any of the previous variants. And really that this is this 69 to 70, this deletion at position 6970 that results in the primer dropout on the TAC path assay and is resulting in the S gene target failure on the TAC path assay. And this is then the sequencing data for 2021. So the graph on the top shows the number of samples, and the bottom shows the proportion of samples, and shows the change in the circulation of variants by sequencing over 2021. And again, you can see there that the beginning half of the year was really dominated by Beta. This was rapidly replaced by Delta during the 3rd wave, and then very rapidly replaced by Omicron from about the middle of November. And we're doing additional sequencing to see how far back this goes, and really trying to understand more about it. But in all the provinces in South Africa at the moment, Omicron has taken over completely in terms of the variant that we're detecting on sequencing. And lastly, and probably most importantly, is once we picked this up, is what the resulting actions were. And I briefly touched on earlier what the responsibilities of a member state are, and really, so we had to look at them and say, okay, well, how do we respond? How do we report? And how do we try to understand this new variant as best we can to give data that's going to be needed? So it was a very rapid reporting. Really just once we got over the shock was, okay, well, we need to let the Department of Health know, and we contacted our Minister of Health. He came back to us and said, well, I'm giving you an extra 36 hours to figure out what's going on, sequence some more samples, and then we need to report this officially. We then reported it officially to the Department of Health on the 23rd of November, to the President of South Africa on the 25th of November. This was followed by a media briefing by our Minister of Health on the 25th of November. And then we requested an urgent meeting with the World Health Organization, where it was declared the 5th variant of concern on the 26th of November. So a very busy couple of days and a very rapid evolving of events. And just to update what you can see in the graph there is it really is being detected in many countries around the world. And I think the latest data as of yesterday was it's now Omicron has been detected in about 83 different countries around the world. Many of which have community spread and community transmission has been observed. So now the stages that we're busy with at the moment is to really try and understand the phenotypic behavior of this Omicron variant. So there's a number of areas where we need to try and understand how is it behaving and what response is needed from a public health perspective. And I just put this table because this is really what we need, the data that we need to get, and we're busy trying to get as fast as we can. The one is understanding the transmissibility of this new variant and seeing are there any changes compared to the previous variants, and is it in the response that may be associated with that? Early data, I think, as you're all aware, showing that Omicron is more transmissible than the previous variants, but we're still trying to understand the basis behind that. The second criteria I was trying to understand is disease severity. This often takes a bit longer to try and sort of disentangle, because it takes longer for once you've been infected. It obviously takes some time for the severe outcomes and the deaths to accrue, but really trying to understand, and this is what we're busy with at the moment, there's some preliminary analysis coming out trying to see what is the effect on the severity of disease for Omicron. Thirdly, the risk of reinfection, and what that means in terms of your population immunity and the risk of individual, number of cases to expect, and the public health response based on whether prior infection confers some level of protection or not. And then the impact of diagnostics. So will the PCR still work? Will our antigen test still work? What effect is it going to have on the diagnostic tests around the world? Then also to understand the therapeutics, what effect does it have on monoclonal antibodies, and what effect does it have on the current treatments that we have available and in our toolbox. And then also really importantly to understand the vaccine effectiveness. The vaccines that we have available, are they still going to be effective against this new variant? And as we know that Omicron has a number of mutations which are concerning for immune escape. And so really all of these rapid data coming out at the moment that it is concerning, but also some reassuring data in that the T-cell response seems to be good and still hopefully protects against severe disease with this new variant. So just in summary, and getting back to really what the purpose of this talk is that how do we keep on top of SARS-CoV-2 variants? And so just based on what I've shown you in our experience, there's a number of key points that all happen very rapidly. The one is close monitoring of your real-time test and case data, picking up the nuances, picking up small changes, seeing increases in test numbers, and really at a lower geographic level. So looking in districts and sub-districts, do we pick up any increases in the tests that are being done, the proportion testing positive, and then the resulting cases, changes in the reproduction number. Very important is the testing capacity. So if I had to highlight one event that really helped us to pick up, to give us an indicator of this Omicron emergence, it was this S-gene target failure. And it was I've put their relationships and communication mechanisms, because it really was a relationship with the private laboratories working together with the public laboratories who alerted us and said, something's going on, please help. Another important part is the real-time sequencing, being able to take those S-gene target failure samples, rapidly sequence them, and be able to get the Omicron sequence so that we could understand and report the emergence of this new variant. And then I think now what's resulting is it's important to have mechanisms in place to facilitate the rapid global sharing of isolates and specimens. And that's something that's really kept us busy over the last few days, is obviously to get the phenotypic data, we need to be able to share isolates and specimens from Omicron infections. And so really to have mechanisms in place that enable that to happen rapidly. And lastly, and probably most importantly, is the collaborations, and really to leverage the strengths of the different groups that you work with. So in order to do the various neutralization assays, the immune assays, to understand the immune response, to understand vaccine effectiveness, it's really being sort of a collaboration between different groups in South Africa and globally, as we try and understand the implications of this new variant and any changes that need to be made in terms of public health recommendations and responses. And that's, hopefully just sharing with you the experience from South Africa. We're still very much in it and still learning, and the views change every day as we learn more. I think it's also been a great learning experience for us, and the building of collaborations around the world. Thank you so much for the opportunity. That's all from my side.
Thank you, Nicole. And what we'll do, try to move quickly. So I'll introduce our next speaker and then leave some time for some Q&As there. You're welcome to post, I'm inviting all the attendees to post your questions and to have an exciting Q&A at the end. So our next speaker is a colleague, dear friend that we've worked together in the past for quite a few years ago on HIV response. He's Sikulele Moyo from Botswana. He led the Botswana Harvard AIDS Institute Partnership Laboratory, which has played in the last decade or so that sort of reference lab role together with some partners and the public health lab in Gaborone. He's also the co-chief scientist of the COVID task force in Botswana, and has led Botswana extensive work on testing programs, and also genomics. Sikulele, you also, as it was South Africa, you led the sequencing and all the work around the new variant of concern, Omicron. And as I said in the intro, we're really thankful to your contribution to the response. So over to you.
Thank you so much, Sergio, and thank you for the panel and also the attendees. Thank you for listening to this and organizing such an important discussion as we learn how to respond to the detection of violence. I hope you're seeing my slides in the correct orientation. Are you seeing my slides in the correct orientation?
Yeah, it looks good. Go ahead.
Okay, thank you. As Sergio said, from Botswana, and this is the institution where I work. I've been working here as a virologist. I've been working here for the past 19 years and grew through HIV pathogen genomics work, and really all my career experience to HIV and many collaborations with the government of Botswana. Some of you might know, Botswana Harvard AIDS Institute Partnership is a partnership between the Harvard School of Public Health and the Botswana Ministry of Health. So it's a partnership and also houses 3 floors of lab space dedicated to mostly HIV. And recently in the past few years has been able to tend to other pathogens, including TB, hepatitis, herpes viruses. So we do quite a lot of work, and it's also a training institution for graduate students, masters and PhDs. So we thank the government for allowing Botswana Harvard HIV Reference Lab to provide leadership in genomics in these areas. And in that context, we developed in Botswana very intentionally early on a genomic surveillance plan. And the genomic surveillance plan is actually embedded as part of the response. And in one of the documents is Annex 4, as you can see, we strategically highlighted what are the areas we are going to look at as a country when it comes to genomic surveillance. And of course, looking at the contribution and the documents that came from WHO and other partners. So in this plan, we intentionally developed 6 strategies and what we are going to do and roll it out to both private and public. And we're intentional that we are going to establish surveillance system to identify circulating lineages, to be able to monitor mutations and changes for obvious reasons, and also to be involved in outbreaks. So we are involved in outbreaks, and that's helped us to identify most of the variants of concern. It was really going out and being engaged in outbreaks. And working with the public health specialists, we are able to get notification of any unusual events in transmission. And with the contact tracing established network, we're able to really get samples out there. But in addition, we are doing random sampling every day of samples from all labs, public and private. They are supposed to sample at least between 10 to 15%. And if it's less than 30 to 50 samples, they take everything and they send it to the lab, to the reference lab. So we work with the National Public Health Lab that receives the samples and sends it to the sequencing labs. So that's how we've been structuring it from the beginning. And we were able through that to detect the incoming beta investigation really out of a workshop that resulted in a couple of infections, and we managed to describe the lineages that were circulating there, and the entrance of C12 as well. We're able to detect through surveillance at the borders, which is one I will emphasize later. Monitoring what is happening at the borders and sampling at the borders is very, very, very critical for understanding importation versus local transmission. When it comes to the Delta as well, when there was an outbreak in India, we started monitoring visitors from strategic countries. And that's how we're able to detect our first cases of Delta, really through our airport screening and sampling strategy, and followed by local transmission of Delta. So in terms of detection of Omicron, I'm going straight. This is the zonal map for Botswana, and is divided into COVID zones. There are 27 health districts, which have been grouped into COVID zones. Really, this was to facilitate control of movement and also to facilitate the response. And all the positive samples from these labs, when they are collected, they sample at least 30 to 50 per day. If they see any positives, at least 10%. And they are sent to the national lab, and we've been using CT values of less than 35. Of course, if there is any interesting vaccine breakthroughs, only travelers, even if the CT values are high, we've developed some methods of concentration of the viruses to be able to at least to see what is happening. And that helped us as well to catch some zoonotic infections and as well to capture some vaccine breakthroughs earlier on, characterized by some of them with high CT values, which was very, very important. And of course, we've established sequencing strategies. We are also part of the Africa CDC Pathogen Genomics Initiative. And I think it's been enriching myself as well. I've joined the NGS SA network, and I think it's been an enriching experience to interact with our colleagues from South Africa as a cross-border collaboration. In terms of dissemination of results, on a weekly basis, we summarize our surveillance work from genomics. We notify the Department of Health, since it's a notifiable disease. Any unusual notice, we use our discretion to see whether we have seen unusual lineages. We report them to the Department of Health. And I think it was very helpful for us when it came to Omicron, because before it was described as a variant of concern, we had tracked it as an unusual lineage. And that was very useful earlier on in the mid-November before we even decided to submit it to GSAID. And that really helped us in interacting with the Department of Health, because we had access now to metadata that helped us to pin down that, of course, this is an importation of a lineage that was very unique. And of course, we submit our results to the DHMT. We also, the DHMT is a district health management teams. When there's an unusual event or unusual lineage or a variant of concern, they do contact tracing, an extensive contact tracing that helps us to see if individuals within the network have been tested, most importantly, as testing strategy. And also to check other important things like travel history. And also we also had a case of a dog. So through that contact tracing, we're able to understand that their dog was symptomatic, and we're able to isolate a virus from there, which happened to be a sublineage of Delta. So that I'm just highlighting the importance of collaborating with the local authorities to enhance testing, to enhance surveillance, and also to get those important samples that feed back to the lab. This is the epidemic in Botswana. As you can see, wave 1 was characterized mostly by a lot of lineages, but mostly the .1.154. The wave 2, of course, similar to South Africa, was driven by the Beta variant, first detected in South Africa. We first detected it in Botswana end of December 2020 through a workshop that involved visitors from South Africa. A chain store, which has also chain stores in South Africa. So we were called into that investigation, and we're able to get in samples that were useful in this investigation. And wave 3, similar to South Africa as well, it was really the largest number of cases, the largest number of deaths in Botswana around July and August, characterized by Delta. And we have since seen quite an evolving Delta epidemic in Botswana with more than 10 or so sublineages detected. And we are interested in understanding what was driving those evolution. And recently, with the detecting of Omicron, we are seeing we have started climbing up in the fourth wave. Monitoring the changes, like my colleague Nicole really eloquently showed how to use laboratory data to monitor what changes might be happening. We also saw similar trends. We saw a sudden increase in positivity rate. And for us, it started, you can see that coming from August, where we had positivity rates of close to 30%, and to around October, where we're really enjoying low positivity rates, going down to as low as 1%. And suddenly, around mid-November, in November here, we saw this pattern of unusual lineages. Actually, the sample was collected from the 11th of October, the 11th of November, I beg your pardon, and sequenced in the week of the 15th to the 18th, and it happened to be in the second batch, which was the 17th and the 18th batch. We do the run over 24 hours. And that's where we noticed this unusual lineage that prompted us to contact the Department of Health. So on the 22nd of November, we had a meeting, and we sent a summary to the Department of Health. And that time we called it an unusual lineage. We called it an unusual lineage because the GSAID at the time, when we submitted it, it actually tracked it as another lineage, which I'll show you shortly. But when we compared the mutations between that lineage and the current lineage we were observing, we realized that this could be a potential misclassification in GSAID. So this is the events that you see. So samples collected on the 11th of November from these travelers into the country for a diplomatic mission. And these samples brought into the sequencing week the following week, which is the 15th to the 19th, and they happened to run the second batch of sequencing. And we noticed that these samples were kind of like outliers in a long branch in a phylogenetic tree. And so what we typically do is we do a phylogenetic tree for a number of reasons. To monitor contamination is one of them, but also to monitor if there's an unusual cluster that is growing from sequences in Botswana. So we noticed this, I don't know whether you can see my laser pointer. So we noticed these 4 individuals clustering together and really appearing like an outgroup. And we wondered what this could be. And upon working back to the lab, we also did, like South Africans are saying, that we went back to the lab just to make sure that there are no issues. So we did a QC analysis. We could have deposited it on this day, but we went back to the lab and we did reassembly and did phylogenetic analysis. As you can see, then we noticed that these are really, really strange viruses that we are seeing. And we decided to let the data go on Monday. Actually, it was the 22nd. And we made sure that the Minister of Health is notified. And I'm still keeping that email because it was like, you know, we have observed an unusual lineage. We do not know what it means. We do not know what are the implications. But if we compare it with what we have seen in circulating, we really need more information. So they gave us access to the information, and we noticed that these were 4 individuals traveling together. And we said, wow, they are traveling together. And actually a pair was a couple, and looking at the phylogenetic analysis gave us confidence, and we released our data. And when we released it on Monday 22nd, it actually became available Monday morning of the Tuesday morning, the 23rd of November. And that was very interesting because it was called, at the time, it was called, it was given a lineage 263, and which was much less mutated. As you can see, this was the initial classification of our sequence. And you can see the number of lineage of sequences there. And also, one of them was also labeled as 524. But this is the actual number of mutations that were there. And really, we have never seen such number of mutations in the RBD than what we've seen before. So that's how we made it let go. And what increased our confidence as well, and a few hours later, we saw 6-7 sequences from South Africa. And we started chatting with our colleagues, Prof. Tulio, who was my PhD supervisor, and started discussing this. And they said, actually, we have observed something similar, and we are currently discussing with our Department of Health about the same. And the following day, of course, it was given a proper lineage 529, and that was on the 24th, I believe, and then on the 26th, WHO described it as the variant of concern. So those are the events, and we started analyzing what is happening with different waves, and we can see definitely a number of mutations that we've not seen before. And some of you may have seen this nice figure from the New York Times just to illustrate the difference between the Delta and the Omicron. And you can see the number of changes that are there. And most of these have been characterized, and my colleague really characterized some of them involved in immune escape, in increasing replication capacity. We saw the P681H, of course, the common D614G, which is very important in replication capacity, but it gained also 2 more mutations that are giving it an increase in replication capacity. So we expect to see a high initial burst of CT values, low CT values, and high viral loads. And we've been looking at our CT values recently, and we see our median CT values actually is between 16 and 17. And we've never seen that with the Delta variant. So we are seeing an immediate burst of very low CT values, meaning it corroborates the transmission dynamics that we see. And if we look at our early...
I'm sorry to interrupt. Can I just ask you to finish up in the next few minutes?
Okay.
Just have enough time for other speakers, and then
Okay, that's good.
Thanks very much.
Good. Yeah. So we see high transmissibility, and workshops, we can see the kind of transmissions that we see. And also, when you characterize those individuals, you see large vaccine breakthrough infections. 61% of the first 40 cases were actually vaccinated. And just to show you that we are increasing proportion of Omicron into the country. Right now, we have almost 148 cases reported in the past few days. We have more cases that we are depositing. And what does it teach us? It teaches us that genomics and intentional genomic surveillance strategy is important. And we see that the other disease programs like TB, HIV, malaria, they've actually in the global programs mentioned the issue of genomic surveillance as very, very important. And for me, just to highlight that testing, especially accessing to testing in very, very remote areas has been very key for us. In the border testing has been very key for us. Increasing access to testing, as you know, our testing rates is almost around 90 to 96 per 100,000 population, which is one of the highest, and also collaborating with public health. And just to close with my last slide is we need functional in-country testing and surveillance systems strengthened. And of course, as you can see, viruses do not know passports. We need to collaborate as a continent-wide networks to make sure that we have a sequencing cores where possible. And also training of local scientists. Data sharing has become very critical, and we also received a lot of questions about data access, data release, how do the world gets to know first. So managing communication, and also I applaud the approach our South African colleagues took, and also the way in which we interact with our Department of Health on a weekly basis, just to alert them. This work is contributed by a lot of people, and of course the health teams that are in the field, and the collaborations that we have, and our funders that have made this possible. Thank you.
Great, thanks very much, Sikolele, and sorry to rush you. Just so much information in so little time. We hope to have time for questions at the end. Our next speaker was scheduled to be Dr. Adetifa, who is the Director General of Nigeria CDC, to give us a perspective from Nigeria, unfortunately, and we can all recognize it's a very busy time, and he was called away, and so they will not be able to join us, but we're fortunate to have Priscilla Ibekwe, who is the Director of Special Duties at Nigeria CDC, who will give us a presentation in their stead. So over to you, Priscilla. Thank you for joining us. And just to note that we have some IT problems, and Priscilla's video, unfortunately, is not working, but I think the audio should work. Over to you, Priscilla.
Okay, thank you very much for this opportunity. I'll be sharing my screen now. Okay. Okay, so thank you very much for this opportunity. I know we're slightly running against time, so I'm going to quickly summarize. It's really about keeping up with the change, the national response to the SARS-CoV diagnostics. So we know already around the global impact of COVID, and I just want to go straight to our national situation in Nigeria to say that we've already till date tested over 220,000 across all states of the Federation. Unfortunately, we've had nearly 3,000 deaths. We've had 3 waves of COVID, and that's the rolling average. Fortunately, the deaths are much lower, and we're very grateful for that. But certainly looking at week 46 onwards, you can see that we're beginning to see some increases in the number of cases, and we're quite taking a big watch on that. Okay, we are very much aware that the strategy is to test, and Nigeria's strategy is to test, to track, isolate, and treat the positive cases as much as possible. Right up, once the COVID was, declared, was notified, WHO was notified, We did a lot of things in Nigeria in terms of preparedness, did our advisories, but the point to note is that even from the 24th of January 2020, we already had the National Reference Lab, activated. And by the time we detected the first case on the 27th of February 2020, we already had 3 labs, PCR labs, while some countries, even in Africa, didn't have any. The point is that diagnostics are so important. Testing is important for individuals with symptoms. We are also doing screening tests for individuals without symptoms, where there are no known exposures. We are doing employee screening, school screening. There's something we call the national service, where youths go and serve in other states of the Federation. And we're also doing the public health surveillance, to monitor the population burden. So we've done a few sero-surveillance studies, which clearly shows that we have over 24% in those states that have been done. Some had like 10% seroprevalence burden, and some had about 25%, like Lagos and the Federal Capital Territory of Nigeria. So like I said, when we started off in 2020, February, we had 3 labs, and we made substantial efforts. Our core principles are to expand our existing laboratory network. We developed the national strategy to scale up access to testing. We expanded existing laboratories. We also leveraged on high throughput laboratories. We had deployment of point of care tuberculosis machines, that's the GeneXpert machines. We quickly enrolled private sector laboratories that had the capacity for PCR and the use of antigen tests. So our laboratory expansion, had to work on the open system PCR, losing our Lassa fever laboratory networks and private laboratories. We had the Roche and the Abbott, leveraging on the PEPFAR PCR, just like the previous speaker has said, having worked a lot on HIV in the past. So we were actually using some of those capacities, leveraging on those capacities. And also on the TB program, we leveraged on the GeneXpert system in the country. And we quickly moved our PCR testing capacity to all states of the Federation. And to date, we have at least 80 we have PCR laboratories in public sector, 80 facilities, and also in the private sector, which I will also describe. One or two are also on our genomic sequencing facilities. So we also in January 2021, as a way of expanding testing, we had the approval of the antigen RDT testing in schools, camps, hospital triaging facilities, big congregate settings where like sports festivals and other congregate settings, including the workplaces. There was a clear-cut algorithm to follow in being able to do that. And so over the period, you could see in 2021 how the testings have been both PCR and RDTs, but most of our testing so far had been with the use of the PCR, about 2.9 million, and RDTs at 700. Just this week, a great group came together to discuss how we can actually expand the use of the antigen RDTs to step up the RDTs across board primary healthcare centers, community settings. So a strategy has just been developed to make sure to help make that happen. So we've also contributed to genomic-based sequencing surveillance. What's going on in Africa. We have 4 laboratories, we have some laboratories in Nigeria, the private, the Redeem University facility, the NRL and 54 Gene, and also the NIMA. Okay, we are also mobilizing resources and leveraging on existing capacity. the core thing really for us is to start simple and establish routine surveillance. We want to support sample collection and shipment, logistics, support sequencing, reagents, equipment, upgrades, and personnel, ensure that we have the systems in place for data analysis, sharing, and interpretation. But currently, these things are all in their, in the starting, what I would say the baseline, the basic, but what we really would like to do would be to scale up and have, be able to work on very big platforms where you have a lot of, you can do a lot of sequencing at a go. So this is the, in terms of the sequencing for variants of interest and concern, we have the NRL, it has the capacity for the next generation sequencing using the Illumina, Mosaic, and the mini Oxford nanopore. NCDC coordinates other labs to accelerate surveillance. We have the Redeemer University EDE, the National Institute of Medical Research in Lagos, and 54G, which is a private laboratory facility. And what the great thing here is that, we are working collaboratively as a country and leveraging and having the same examples that has been highlighted by other presenters. It's very important that both the private laboratory and the government public sector need to be working together to fight, to address a common concern that that affects the country. So to date, we've had about 3,754 viral genomes. You can see the space over the period that Nigeria has contributed to the global database. The lessons we've learned from the COVID-19 pandemic is that there is a critical role for diagnosis. It's important that it's available and accessible, as it has a very strong role in outbreak response. We need long-term commitment in our programs to support staff, to support staff in the high numbers, both in their skill mix, quality and training, continuous training. To every day you learn new things, and you need the staff to be able to upgrade to catch up with the trend of what the viruses, how the viruses are behaving. The issue around laboratory quality control, quality assurance, biosafety, and biosecurity. To support this, we also need, we've learned that we need strong supply chain management systems, strategic national stockpile of reagents and commodities, so that one is responsive to the different parts of the country as we see the burden of disease, the burden of infections. We also have the genomic surveillance. We've also learned that genomic surveillance is instrumental for continuous monitoring of emerging and re-emerging viruses and variants of concern, and continuous efforts are needed in both basic and molecular research that cuts across all pathogens of interest. The core point here to note, before I go to the last slide, is the need for countries like Nigeria and other African countries to scale up, their testing capacity, ability to provide real-time sequencing data, and have that capacity also for genomic sequencing. Not just, so, for example, in Nigeria, in the NRL, for example, we're able to do just 92 in a day. When in fact, if we had better platforms, you could do. Some countries are able to do 3,000, tests all in a day. So important thing is really to make sure that you start off somewhere, but that we have the resources and the capacity of staff to be able to scale up. So we are grateful, and we acknowledge all our partners who have supported the work, and we are very happy to be at this forum to learn as well as to contribute to what Africa is doing. Thank you.
Great. Thanks, Priscilla. Right on time, spot on. And you provide a really good segue for Belinda, our next speaker, when you highlight the issue of diagnostic availability and access. Early in the pandemic, when some of us were really struggling to ensure that the Global South had access to diagnostics, something that you all probably were well aware. We soon realized that the raw materials were critical, right? Raw materials to produce both molecular and non-molecular, like lateral flow assays, became really scarce. Even the plastic, the casing, and never mind all with the lockdowns that started to take place, to even move commodities across the globe became absolutely impossible. And I had the pleasure of meeting Belinda Shaw. She's the CEO of a company called Cape Biologics, and they produce some of the most interesting recombinant antibodies for various users. And more recently, they with us ventured into producing key components of lateral flow assays using plant-based technologies. I want to highlight a couple of things about Belinda. She's a woman entrepreneur. She's from Africa. She's passionate about business development and contributing to our continent in a humane way. She has the work ethics and that is remarkable. And I had the pleasure of meeting some of your colleagues and workers, and your example of how things should be done in an ethical way, and also to contribute to the local growth of not only intellectual power, but many of other role players in our community. Belinda, please, you do exciting work and links very well with what other speakers have already highlighted. Over to you.
Thank you so much, Sergio. Thank you for those kind words. I am humbled. Just checking you can see my screen and you can hear me fine. All good?
All good, all good. Go ahead.
Fantastic. So I'll be as quickly as I can. I know that we're up against the clock. So yeah, thanks to all the participants as well. I mean, really an honor to be here. Cape Biofarms is a spin-off of the University of Cape Town. We opened our doors, or started, in about 2018. And Cape Biologics is a subsidiary of Cape Biofarms. It's our manufacturing subsidiary. And so you know, what do? We produce plant-based recombinant proteins. When I say plant-based, we use a plant-based platform. But just to look at where and why we started, and the reason for being is our passion to contribute to building a strong, self-sufficient and sustainable manufacturing capability in Africa, particularly for production of biologics. So this is contributing to biosecurity. And Priscilla, it's exactly what you were mentioning earlier on. And it's not just biosecurity. We really are passionate to contribute to building the skills and capabilities in Africa. I mean, we definitely have some incredible people, and I think all the presentations previous to mine are just mind-blowing. It's amazing what your teams are doing. And so we want to contribute to that. We've got a young and vibrant continent, and I think we do need to stand independent and empowered to meet this challenge, which, as I put here, is a war against disease, and it really is a war. You know, and I think we know Africa in a way has been standing in a queue for a while, and I firmly believe we do not need to do that any longer. We have the capabilities, and I think the plant-based platform is a fairly disruptive, and it's a very enabling technology to achieve this. So biofarming, this is essentially what we do. It's a technique of genetic engineering. We insert codes, or genes, sorry, that code for useful pharmaceuticals in host plants that otherwise would not express those genes. And this is our host plant. This is how we express different pharmaceuticals. It's called Benthamiana, Nicotiana benthamiana. It's a distant cousin of tobacco, and no, you can't smoke it. Although we had a lot of people asking us when we were in lockdown here, when people couldn't buy cigarettes. I thought that was quite hysterical. But these plants are very good at producing proteins, and we just trick them into producing a foreign protein. This is what one of our grow rooms look like. It's a hydroponic vertical grow room. It's environmentally controlled, and we grow these plants to about 5 or 6 weeks, and then we infiltrate them with whatever gene of interest we want. And that gene of interest ranges across research reagents, and we're focusing on diagnostic reagents, but those same reagents can work for therapeutics or vaccines equally well. And we're really excited that we've secured an EIB facility that will allow us in the not too distant future to build a CGMP, a plant-based CGMP facility that we can start exploring the plant-based capability for therapeutics and vaccines. So I think just a very, very quick overview of the science and how we do it. It's premised on the very fact that DNA codes for protein. So we get the sequence of any protein we need, and this is critical, and I think where collaboration can really work well for us is securing the sequence of particularly Omicron. Took us a little while, securing the sequence of Delta or any of the others. Takes a little while. So if there was a sort of a bank or a data bank or a place we could go to that was instantly available to secure these sequences, it would speed up our process immensely. So once we've got that sequence, we codon optimize it, we edit it in a way that it can be expressed in plants. Then we take that sequence, we have to have it synthesized, turned into DNA. And this is also somewhere where we're looking at shortening that time frame, because we have to send it to GenScript in Hong Kong that does that and it comes back. So we're subject to courier and the vagaries of the courier system. So once we've got the DNA, we then insert it into the Trojan horse, which is the agrobacterium. And agrobacterium, the plant has no sort of mechanism to defend itself against agro, particularly Nicotiana. It's got a very sort of low immune system. So we get our DNA of interest, our gene of interest into agro. We then, through a process of negative pressure, vacuum infiltration, we insert all the agrobacterium gets sucked up into the leaves, and then the plants sit in the incubation room for another 3 or 4 days. And it's amazing how quickly and how much protein can be produced by these plants in a matter of days. And the plant system loves antibodies. We have very, very high yields, anywhere from sort of 20 to 150, 200 milligrams per kilo of biomass. So it's a very, very responsive system. And then we harvest the leaves, we turn them into a smoothie, and the purification process and QC is pretty much standard. And I mean, just to give you a very brief overview of the advantage of the plant-based system, particularly for African LMICs, we don't have the massive and traditional systems like the mammalian cell culture systems, big, huge, very, very expensive stainless steel, very high level of skills. Our bioreactor is a single-use, low-cost, biodegradable plant, and we build thousands of plants. And in terms of the platform, to build the platform is 1/10 of the cost of traditional systems. We built ours in 6 months, very, very quick. It's infinitely scalable. We just add more plants, very flexible, rapid plug and play. We can put in any product. We can literally decide a week before what protein we want to put in the plants. And this is a system that can ensure the local supply of reagents. And this is where we're very passionate about biosecurity. And I think that it translates into the actual proteins themselves. Very briefly, very high intrinsic safety when we're getting into therapeutics or vaccines. We don't use, there's no sort of the transfer of animal pathogens in any way, there's no risk. And all our genes are done or fused at genetic level. So it's literally a copy paste process, and it's exact replica, very quick speed to market. We know we have superior economics, particularly techno-economic analyses that have been done, very rapid scale up, ability to produce complex proteins, which is quite unique to plants, and it's, many other systems cannot produce these complex fusion proteins. Agility and flexibility, I've mentioned, then an ethical choice. No animal or animal products are used in our system. Very committed to the One Health initiative. We know the linkages between animal, human, and environmental health. And particularly, we know where Ebola comes from. We know where COVID comes from. Well, we kind of know where COVID comes from. But it's all linked into human and animal health, and particularly in Africa, where animals are such an intrinsic part of life. I would like to just show you this little video, because it's just shows you what we do, and I think it's a bit of fun.
Is the audio on, Belinda?
Very briefly, just taking you through our capacity, we can now produce over 100 kilos of biomass a week, which is quite a lot when we look at our yields of sort of 20 to 50 milligrams per kilo of biomass. Our production capacity, we've now upped that quite substantially. We can produce about 20,000 milligrams of any particular protein, again, depending on yield. And if we look at test kits, normally it's about a microgram per test kit. So this is enough protein for about 20 million rapid diagnostic test kits. And we've increased our pipeline. We've got a whole suite of SARS-CoV-2. And then we're moving into now antibodies for beyond COVID, malaria, Ebola, yellow fever. And what's really exciting is the plant-based system and how it can respond to all these different requirements. So this is just a very brief overview of the proteins we do have for the different test kits. And I think this is, for me, one of the challenges is we like to provide a whole suite of proteins for our local test kit manufacturers, because that ensures local supply. And we found out, particularly even now, one of our test kits has been approved by SAPRA, and they're battling to get some of the other reagents that were on those test kits at the moment. So they're going to have to wait 3 or 4 weeks, which is really concerning. And that's why we want to be able to produce this whole suite of proteins to ensure that security of supply. This is just going forward. Very exciting progress here in terms of what we can make in the plants. And many of these proteins you see here are what our local kit manufacturers have actually asked us to do. So we're well onto Ebola, yellow fever, malaria. These we know will express in plants. We're busy with a very exciting fusion protein for HIV, 3641. That should be coming through early in Jan. And then we'll be moving into veterinary diagnostics. And we know this collection here actually express in plants. So we just need to optimize it and ensure we improve our yields. So very exciting in the latter part of next year. Where do we want to be? The future, we really do want to contribute to future-proofing the next pandemic with plants. Our idea is to have multiple nodes of plant-based platforms in various critical regions so we can respond to regional needs. We have South Africa. We're hoping holding thumbs, Senegal, Mauritius, and then potentially going beyond into other LMICs. And I'm really excited about the 100-day mission, particularly putting diagnostics at the forefront of routine healthcare, and then the diversity of platforms for different reagents. But I think to get onto the essence of it, the manufacturing challenges we've experienced in the last sort of COVID period, 2 years, 18 months, is we need to get timely access to antibody and antigen sequences so that we can produce the full suite of reagents for a test kit. And I think that would speed up things very rapidly. We can move very quickly as it is, but we need to shorten the time from, as I mentioned, getting the sequence to the DNA synthesis. Internal formulation, we are now going to be developing our internal capability to formulate test kits with our protein so we can produce a ready-to-go complete package to assist locally produced kit manufacturers, because there's a lot of backwards and forwards in tweaking the reagents so that the formulation works. And formulation on a test kit is an art. It really is an amazing process. But we do have a block, is many of our proteins have gone to test kit manufacturers, and then they have to submit, obviously, for regulatory approval. And there's been a very, very slow process, and fully understand the challenges that SAPRA faces, but it has been a blockage to market, and it has had a massive impact on the financial sustainability, I guess, not only of our business too, but also of test kit manufacturers. So we are working together with test kit manufacturers to also send ready-made kits for regulatory approval internationally, just so that we've got a safety net. I think one test kit manufacturer has just had their antigen kit approved, but that took almost 18 months. And we've got another test kit manufacturer we work closely with, they're still waiting sort of 9 months. So, you know, to speed up this process is absolutely critical. And as I said, I fully understand the challenges, and whatever we can do to contribute, we gladly will do that. From the kit manufacturer point of view, just chatting to all of them in preparation for this, one of the big things was a biobank to be made available so that they have blood samples to access quickly. Again, they mentioned regulatory blockage to try and speed that up. Imports, a lot of imports flooding into the market, and a lot have been tested by these kit manufacturers. Many are substandard, many work well, but some don't, giving diagnostics, you know, bad PR. and the feeling that there needs to be more of a commitment to fast-track locally produced kits to speed up that process. And again, I think the need to develop perhaps in the future a single regulatory authority or one set of protocols that can support all kits being made in different regions so that we can speed up the capabilities and capacity for clinical trials licensing. And then these kit manufacturers too, obviously funding to scale up their production capabilities. And we're already getting involved in the distribution sales network for test kit manufacturers, because if they don't sell, we can't sell. So we kind of joined at the hip. But it's been an incredibly challenging year, I think, for everybody. And I think it's going to be even challenging next year. And I'm super excited about the developments that are going to take place and our growing pipeline of products. So thank you for giving me the opportunity.
Great, thanks very much, Belinda. I think your last statement, I think we all recognize it's going to be a very challenging year ahead, but it also, we can be optimistic that what we've seen this morning, we are up to that challenge. So thanks very much for that. I'm sure Sergio will probably got a smile. We're particularly interested to see that you mentioned the 100 Days mission, because that's one of the activities that FIND has been very engaged with, and thinking how do we both get out of this mess in real time, but how do we make sure that this sort of thing can't happen in the future. So I think there's a lot to do, but we can still be optimistic. We have time for a few questions, and we could probably extend for hours with all the questions that people might have, but I wanted to start, if I could, and just the whole fundamental challenge of testing. And we've thought about, and of course we think about FIND, how do we put tests in place? But it doesn't work, of course, if people don't want to get tested. And so for those of you who are working on a national level and a public health approach, what are the challenges that you're seeing to people, the uptake of testing? And so you can provide PCR, provide rapid tests, but what are the challenges that you see? Maybe starting with you, Sikulele, if I can, in Botswana, what's the uptake of testing and what are the barriers? Over to you.
Thank you, Dan. Fortunately, the testing, the demand for testing sometimes outstretches supply. So we have been fortunate that quite a number of people really are testing. And I think our testing strategy as well, we've been trying to reach out to different corners of the country. And that has really enabled us to increase access to testing. And of course, the challenges we've had is running out of commodities. It's not the appetite for testing, it's running out of commodities. And I think we've had challenges where we've gone at some time, weeks without tests, the supply chain, and that has been the challenge. But our ports of entry are all testing. Our remote areas, we've sent experts rapid antigen tests in those areas. And one of the challenges, of course, has been human resource. Increasing access to testing also requires training, different level cadre that can be able to do the simple tests, like healthcare auxiliaries that you do not require a nurse or a doctor or a lab technician to administer this test. And I think that's where we are going in terms of expanding testing as well. But otherwise, the appetite is great. The expansion is ongoing. And we are also thinking of test drives, where you have bus drives through the bus ranks or through certain areas. The same way we are doing with vaccination. Right now, we are doing drive-throughs vaccination. We are thinking of drive-through tests as well, just to help reach, especially the young people. That's where the challenge is. Accessing testing to the young people is often challenging. So we are thinking of increasing that access.
Great.
Thanks, Sikulele. I know Sergio has a question, but I wanted to just first go to Priscilla and see if it sounds like in Botswana, the demand is there, but the supply is perhaps the challenge. Is that your experience in Nigeria, Priscilla?
That's not my experience. As a matter of fact, I wanted to put up my hand to ask what is Botswana doing? How can we learn from them? It's quite frankly the opposite. I think the use of the initial social media, and the fake news that came from the social media, in as much as we tried to, disperse as much of these infodemics, infodemic analysis and trying to disperse some of the earlier wrong notions that was going on in the social media. We are experiencing the opposite, quite frankly. People are not really wanting to test. So a lot of work has been done with religious leaders, with community leaders, going right down to the community. Quite frankly, some community members don't even think that COVID exists. So it's really the opposite, and I'm happy to read around what Botswana has done and how they have been able to change the tide from their own perspective. But for us, it's the opposite. So we are working more on demand creation for both testing and treatment.
Yeah, good point, Priscilla. There were political leaders from the G7 that didn't also believe in that. But again, Dan, I'm not going to get into the politics of pandemics. I had Nicole, Priscilla, Sikulele, something I want to ask all three of you regarding the response. I mean, the way you describe how things happen and address seems kind of serendipitous, like I know exactly which lab it was that rang the bell thinking, did I miss the primers? How come I'm seeing so many deletions or mutations, etc.? I know it's a close call, this maybe, but it sometimes gives you the sense that if it wasn't for a network that is quite delicate of colleagues of yours, Nicole, Sikulele, and Priscilla, that needs to be really open, accessible, and ready to ring the bells, right? How do you think we're ready for the next variant of concern? And are we especially all three of you, making sure that we take good notes around how we responded to this one and be better prepared? That's one thing. Second question is, none of this data, genomic data, gigabytes of data, are going to be of much use if the metadata or the clinical part of this is not tied together. So Nicole, we can produce terabytes of genomes, but if we don't even know where these individuals are they or not vaccinated, and basic understanding of what symptoms they're presenting with, right? It's going to be futile, because it's not going to, as Priscilla points out, there's misinformation or disinformation of vaccine performance and hesitancy is going to end up with the wrong message, right? And then my third question, Dan, if you can allow me and see how we respond to this. Belinda made it very clear, without the connection, without understanding, for example, that we need a consensus sequence and not only ring the bells of those who need to understand how to get WHO aware, industry is ultimately going to be responsible, for most part, to produce diagnostics that remain relevant with new variants of concerns and many other pathogens. So how can we, and this is a call for you, Nicole, Priscilla, and Sikulele, to ensure that once we also know that there's something cooking here, a variant of concern, that we have a channel to communicate this to the Belindas of the world so that the diagnostics remain safe, and we can continue banging on the message of test, test, test. Okay, so 3 questions. Dan, you help me here, moderate. Over to you.
Okay, who would like to come in on any of those? I guess.
I'm quite happy to start off on a general note, and my colleagues can give more of the specifics. I'd like to start by saying that, as you know, that the Nigeria Center for Disease Control is a new organization, a new agency, a parastatal of the Federal Ministry of Health. And we are very, very clear about the fact that we want to build an organization that the public can trust. We want to say it as it is, use the science to guide, the evidence, the science to guide decision making. So we would present what we see. And in doing that, it's very important that, so for example, all our as far as I know, the all positive cases coming from the ports of entry into the country, out of the country. Once we have a positive case, we go ahead and do the sequencing, and we tell it as it is. And we also try and link up with the case management. We have what is called the public health EOC, that's the Emergency Operations Center for COVID. We meet once a week minimum. And if anything, so this is a combination multi-sectoral approach to dealing with the national, our national response to COVID-19. Not only are we doing it at the national level, also we are linking up with states at least once a week, or I think about twice in a month. It depends on how things are going. If we need to do it more often, we would. Right. The point and the summary of my point really is, we are an organization, a learning organization. We want to use the science to guide the policymakers, and whatever we see, we would say. It doesn't matter what the negative, for us really, we hope that what we say would help, and we want to continue to maintain the collaboration between the private sector and the government, that is the government public health facilities. Yes. So we'll work. I'm mindful,
we've got 3 minutes, and I really want to hear from Nicole and Sikulele. I don't want to leave them off the hook. Nicole, and then Sikulele, and Belinda, if you want to also comment. So make it quick, snappy.
Yes. I'll try to be quick. So I agree with you. It was completely serendipitous that we found Omicron. I think we have a very good sequencing system. I think we have, we really thought if we're going to pick up the next variant, that's where we're going to find it. We look at the data very closely. We get samples from all over South Africa. We meet 2-3 times a week to look at minor variants that we're picking up, and we thought that would be sort of the place where we pick up the variant, and it wasn't. I mean, it was in the testing data that really led to it, and only later on through the sequencing found the details of the new variant. So I agree with you, and I don't know. I think a combination of all I spoke about in my talk. I think in hindsight there were signs everywhere. But hindsight's always easier than foresight, right? But I mean, we saw these rapid increases. We saw strange things. We were like, what's going on? And sort of didn't know. In hindsight, there were actually early warning signals to us. So possibly to pay more attention to that. But I think don't underestimate the value of, the labs who are looking closely at the data
sure.
And pick up really any nuances. And it really was a lab technologist sitting in a private sector laboratory that picked this up. And I think that's really valuable, the people that are looking at the test, not just the mass data.
Absolutely.
The country, but and then to have, like I said, the reporting mechanisms that someone, those networks, that they can raise the alarm and it can be investigated, was what we learned from this.
Yeah, just to add on to what Nicole has excellently said, I think having an intentional surveillance system helps. Of course, you never know when you are going to see a variant, but if it finds a context that is well structured, for example, random sampling every week, every lab submitting samples is going to be key. And point of entries, random sampling is going to be key. And also, I think one of the lessons we learned is really engaging your local health officials for policy. And there were issues around releasing of the sequences publicly. When do you release it? As scientists, we believe in open transparency. But because of the backlashes that you see in travel bans, there have been questions already to some of us as scientists. Look what you have done. Our country is blacklisted. Or look what you have done. You've spoiled our Christmas. And slowly, when these discussions are going on, people are now realizing, oh, actually, it was important that you let the data go. But the initial reactions suggest that we need to do a lot of work around policy, around making sure that we have the actual data. And also metadata was very important. You saw that we detected it early around 17, 18 November, and engaging the Department of Health really helped us to understand where these individuals are coming from, their vaccination history. And so integrating with the response, you cannot just do the sequencing and enjoy seeing those trees, but you need to see what does it mean for public health. And I think that's where really the system was set up to respond in terms of the alert mechanism we have every week, and also notifiable disease requirements, that if you see anything unusual, even if you don't know what it means, report
Yeah.
it.
Yeah.
Dan?
So, yeah. Apologies, we're going to have to wrap up. We're at time, but if we were in person, we would be giving all of our speakers a big round of applause. So very much thank you for being with us this morning. Apologize to those who were sending in questions that we didn't get to today, but nevertheless, I think that we really had a great session. It really starts to a conversation, probably then finishing it off. I'll end with just a few words. Can't help but putting a plug for if you're interested in either of these organizations. So we're here in Geneva, the Global Alliance for Diagnostics. Please check us out as our website there. And then the American Society of Tropical Medicine and Hygiene. Certainly encourage you to check us out there at the website and join us as a member, but also for our annual meeting that comes up next late October and November in Seattle. We hope for that to be in person, but it will also be online, and who knows what the future will bring. So thanks very much to everyone for joining, and have a good rest of your day. Bye-bye.
Thank you.
Thank you. Thanks, everyone.
Bye-bye.
Bye.